Welcome back. We are working on the heart and specifically in the heart physiology. I'd like to start now on heart sounds. What actually makes the heart sounds, which is the valves, slam and shut. We have those two sets. One's going to make our lub and one's going to make our dub sound. And we'll go through that process. Also like to then start in on the mechanical events of the cardiac cycle. We will work through that process as well. And last but certainly not least, the cardiac output. We're going to do a little bit of math, a little bit of equations there. I promise it won't be too painful, but we're going to talk about the pressures that are caused by the contraction of atrium, the contraction of the ventricles, and also that output. What volume are we pushing, depending on how fast our heart is beating, depending on how much of a squeeze we get in that systole stage. Remember, during fight or flight, we can, hello, nice to see you. Bye-bye. Remember, we can increase the output of the heart when we have that fight or flight tie-in from the autonomic nervous system. It increases the heart rate, but it also ties into those ventricles and has them squeeze a little harder, so pushing more volume as well during that fight or flight response. That is what we will finish up with on this portion. So first, let's start with the heart sounds. All right, back to the big picture. Our heart sounds for the first and second, our lub and dub, occur if we follow down here to ventricle contraction. Right? Ventricle will go into systole and contract. That is going to slam some doors shut so we don't push blood back into the atrium. Lub. And right here, our second heart sound, our dub, if we follow that over, right, is we're going to have some pressure of all that blood that got pushed into the aorta. You have to be kidding me. All that blood that got pushed into the aorta and into the pulmonary trunk, trying to get back because there's not enough room in here and it hasn't moved all the way forward and downstream yet. So we'll have that little pushback from those two, which are going to slam shut our other one-way doors, those semilunar valves. Hence, following this line up here, shutting those. There's our dub. All right. Let's look at this in a little more detail. The two sounds, that lub-dub that people talk about, is associated with the closing of heart valves. So first, as I showed you, the AV valves are going to be the ones that close first. From the ventricles contracting, remember they don't want blood going back into the atrium. These are one-way doors. So as we start to squeeze here, those are going to be slammed shut. Okay, the chordae tendineae are going to hold on so they don't flip and open in the other direction. No idea why it keeps doing this. I apologize. And that is our first sound. Beginning of ventricle systole, slamming those AV valves shut. Lub. The second is as the semilunar valves close. So we pushed all that blood up into the trunk. We pushed all that blood up into the aorta. And then as the ventricles relax, that leaves a little space for that blood to come back down and relieve that pressure. Well, these guys here, them semilunar valves, aren't going to let it happen. And they are going to slam shut, hence our second sound, the dub. There's a slight pause in between those, and that indicates that heart relaxation time where the ventricles just squeeze for a little and then start to relax, and then we're going to have that backflow slam those semilunar valves shut. What could possibly go wrong here? Well, let's talk about a homeostatic imbalance, heart murmurs. All right, abnormal heart sounds. So this would all, yes, don't show me this message again. So, and focus. So the heart murmurs is going to be a term for abnormal heart sounds, and that can be a number of different heart sounds. We got a couple that I've listed here. First, incompetent valves, which I think we talked about previously perhaps, but we'll discuss again here. Those incompetent valves. These are the ones that won't close completely. So if they don't close completely, we're going to have a little flow running through there, a little swishy noise that you will hear with your stethoscope. All right, and by where you place your stethoscope, you can figure out which valve it usually is. Also, stenotic valves. These are guys that don't open completely. So we will have them open, but not entirely, for that whole flow to rush through and not create any pressure or any high-pitched squealing sounds. So the best thing I can compare this to is when you blow up a balloon. If you just let it go, it just blows out. No high-pitched noise, right? It lets all that air out because of the pressure. Stenotic valves is like when you take where you blew the air in and you squeeze and pull it tight and it makes that high-pitched squealing out of the air rolling through. That's the same thing that the blood will be doing rushing through, where it's just not completely open, that high-pitched squeal. Obviously not as loud as the balloon, but you get the picture. I'd mentioned that you can hear which valve is being naughty depending on where you place your stethoscope. All right, I am not going to ask a question, which valve will you be hearing if you place your stethoscope at the second intercostal space at the right sternal margin? But I know these are things in health field that you are probably going to be seeing as you move through and actually start working on patients and rotating through clinicals, things of that nature. So this is what I want to share with you. By placing the stethoscope in different places, you get closer to certain valves than others to be able to hear them. And this is a pretty important thing. And I'm sure every time you've gone to the doctor, hopefully the doctor has listened to your heart and moved the stethoscope around into these different locations. That is why. Checking out the different valves. Thanks, Doc. Question. Your lub-dub heart sounds. What are they produced by? What is the sound produced by? Okay, if you say A, walls of atria and ventricles slapping together during contraction, flick yourself in the head. The blood hitting the walls of the ventricles and arteries respectively, also a big X. Okay. Closing of AV valves lub, closing of the semilunar valves dub, or is it the opposite, closing of semilunar valves first, the lub, and then the AV valves dub? C or D, 50-50? Final answer? Correct. It's all about the contraction and then relaxation of those ventricles. So closing of the AV valves is going to be from contraction of those ventricles, slamming them one-way doors shut. And then as it relaxes, that blood trying to get back to the easy space where there's low pressure is going to slam them semilunar valves shut and give us our dub. Moving on, the cardiac cycle. Let's start putting the pieces together of your ECG, causing the heart to contract and relax, causing valves to slam shut. Valves to slam shut. I can say that. And squeezing out volume as we roll through there. Atrial systole, ventricle systole, causing differences in pressure in the blood, for sure. Differences in pressure in the aortas. We shove that 70 mils in there. So let's walk through these stages of filling, systole, and early diastole of the ventricles, because that's what it's all about, people. Getting this blood either to the lungs or getting this blood to your body. The cardiac cycle. Blood flow through the heart. All right, one complete heartbeat is considered your cardiac cycle. Atrial systole and diastole, followed by the ventricular systole and diastole. And I believe I've mentioned before, but just in case, systole is the term for the contraction. So anytime the atria or the ventricles are in systole, they are contracting. And I remember that by the S being scrunchy, like the muscles are contracting and squishing up. Diastole is relaxation. All right, those muscles relaxing and opening up the atria, opening up the ventricles. D, I think, is a big open space, so that makes me think of relaxing and opening up those chambers. When we give a squeeze or when we relax, that is going to cause pressure changes and blood volume changes. When we squeeze, pressure is going to go up and volume is going to move on to the next stage. All right, when we relax, pressure is going to go down and blood volume is going to start filling in that chamber. Kind of makes sense. First phase, cardiac cycle. The ventricular filling, phase 1 right here, takes place mid to late diastole. All right, so we're going to have that happening. Ventricular filling, atrial contraction to give that last little push of blood into the ventricles before they give their squeeze. The AV valves are definitely open as that blood flows down from the upper chambers into your lower ventricular chambers. Pressure is low because we're just filling this tissue up. All right, no big squeeze yet happening here, no big pressure changes. Actually, think about how thin these atrial walls are. 80% of the blood flow that fills into those ventricles just passively flows. It's not gravity, but it passively flows into the ventricles. When those atrium go into systole or contract, that's when we deliver that last little bit, that 20%, to get those ventricles up to their 100% fill, which is about 70 mils per ventricle. So that volume is considered our end diastolic volume. So the most blood that's going to be in those ventricles while they are relaxed, they're in diastole. So volume of blood in each ventricle at the end of ventricular diastole is considered your end diastolic volume. That's when they are the fullest. Phase 2, we can break that into A and B, which is going to be ventricular systole, right? The contraction of your left and right ventricle. The atria are going to relax. They've done their little 20% squidgy, so they are going to relax now. We remember this from our ECG. And the rising ventricular pressure there, as it gives a nice contraction, is going to cause the slamming shut, or that lub, of those AV valves. They are going to slam shut, lub. This is going to lead into the ejection phase, where we are going to eject that blood out of your right and left ventricles, right? And this is going to cause higher pressure, right? We're squeezing down on this volume. So it is going to cause a higher pressure in the ventricles, which is going to open up those semilunar valves and push that volume into the pulmonary trunk or the aorta, is going to add pressure to those large vessels as well. When we are at our strongest squeeze, okay, that ejection phase, when we're at the tightest squeeze there, that is when we're going to have the least amount of blood in our ventricles, because we are going to push it to the lungs or to the body, and that is then considered our end systolic volume. All right, the volume remaining in each ventricle after contraction. We don't have complete squeeze out. The walls of the ventricles don't touch each other. There's going to be blood left, and that is your end diastolic volume. All right, but during that squeeze process, you can see over here that pressure in that ventricle, this one is the left ventricle, is a very strong push, which increases the pressure as well in the aorta, the green line. Last but not least, step 3 here, we've got the isovolumetric relaxation. Iso meaning kind of equaling out, isovolume relaxation. So this is very early diastole, where the ventricles are going to start to relax and they are going to start refilling. Ventricles relax, the atria are relaxed and filling. This is a good time, even Stevens. Backflow, because we had that big push in the aorta and the pulmonary trunk, they are going to try and backflow into this nice open space that's being created, and that is going to cause those semilunar valves to say heck to the no, and they are going to be slammed shut by that blood trying to go in the wrong direction. This I find very cool, the dicrotic notch. I don't know if anybody looked at this and thought, what the heck is that V there? It is a dicrotic notch. And this is caused because we're looking at pressure over time. We do that big shove of blood volume into the aorta, and then there's that decrease in pressure there, and then a jump increase in pressure really quick. What's happening there is that brief rise in pressure is because the blood itself is rebounding off that closed valve. So it's trying to get out, and then it's like, oh, valve shut, crap. And the pressure increases just slightly as it rebounds, and then the blood flow will move down the aorta into the body and, of course, decrease that pressure then on the aorta walls. Last but not least here, when atrial pressure exceeds that of the ventricles as it fills up here, we are going to have those AV valves be pushed open again when the pressure's higher over here than in the ventricles. Remember, they're one-way doors. They are going to be opened. No sound, just the doors opening. They only make the sounds when they're slammed shut. This is going to allow for ventricular filling, which basically rolls us back to the beginning of stage 1. Ventricular filling, 80% flow in, extra 20% from the atrium squeezing. All right, ventricle squeezing, pushing blood into the lungs and into the body, relaxing a little bit, blood flowing back into the atrium then refilling the ventricles again, and around we go until we get dizzy. Talked about the cycle here. Basically touched on these big terms here, talking about the ventricular volume. End diastolic volume, which is where we're at our greatest volume in the ventricles. Big old squeeze leaves us with just that little bit left in the ventricles, and that is our end systolic volume. The difference between the two is what we squeezed out, and in this case what we're measuring here is the left ventricle, so this is what we squeezed out into the aorta. If you recall, we move the same amount of blood volume from the right chamber as we do from the left chamber, so the image would still be the same. The stroke volume, SV, the amount of blood pushed out of the right ventricle, will be the same as the left ventricle in a healthy heart. Let's dig a little deeper. Cardiac output. Volume of blood pumped by each ventricle in 1 minute. So, how many times do the ventricles contract, and how much are they pushing out with each contraction? Say it this way. Cardiac output equals your heart rate, how many times you're squeezing, times the volume you're pushing out each time. That's stroke volume. Heart rate times stroke volume equals cardiac output, and we measure that in a minute increment. The normal, the average amount of volume pushed in a minute I'd mentioned was pretty much the volume in your body, right? Around 5 liters a minute. You are pushing through your body. Every red blood cell is making its way out of the heart and back to the heart in a minute. Let's do the math here then. Cardiac output is mils per minute. That equals, again, the heart rate times the stroke volume. So, in your heart, if your SA node is not being mucked with by your nervous system, you have about 75 beats per minute. You push about 70 mils on average out of a ventricle. Multiply those two numbers, you get 5.25 liters. So how do we mess with cardiac output? By altering heart rate or stroke volume. If we increase stroke volume, we're going to increase cardiac output. If we increase the heart rate, we're going to increase cardiac output. If we decrease, guess what's going to happen? We're going to decrease cardiac output. So cardiac output increases if either one or both heart rate or stroke volume are increased, and vice versa. If we drop those, we're going to drop cardiac output. Maximal cardiac output is usually 4 to 5 times your resting cardiac output in non-athletic people. So at rest, couch potatoing, you're doing about 5 liters. If you're not a very athletic person, you don't run marathons and work out every day, your max before your heart's going to get really cranky is going to be 4 to 5 times that. All right, so 20 to 25 liters or so. However, in trained athletes that work really hard, that have exercised their heart just like they've exercised the other muscles in their body, they can get up to 35 liters a minute. All right, so up to 6 times, 7 times cardiac reserve. This term is the difference between your resting and maximal cardiac output. It's the reserve you have between couch potato and maximum output. You are at full-fledged workforce with your body. All right, so cardiac reserve is going to be greater in those that are trained athletes that are working hard and exercising their body. Cardiac reserve is a smaller number for those of us that are couch potatoes or non-athletes. All right, tell me again, cardiac output, what is it determined by? Is it determined by your heart rate, your stroke volume, cardiac reserve, or both, a combo of heart rate and stroke volume? As you look back a slide previous, you got it, both A and B. Cardiac output equals heart rate times stroke volume. Bam. Average. Red blood cell runs through your heart and back around every minute. How do we regulate stroke volume? Right, if we are going to increase or decrease cardiac output, we can mess with this number. How do we up the dosage or lower the dosage in the volume we push out of the heart? We looked at that. Ventricular volume. Remember, filling of the heart, filling of that ventricle to the greatest volume is the end diastolic volume. When we do the big squeeze and squeeze out the stroke volume, we do have a little bit of blood left, and the max that we push out will have the smallest volume in the heart, which is our end systolic volume. What affects these guys? Okay, what makes the difference between a big stroke volume and a little stroke volume? The end diastolic volume can be affected by the length of the ventricular diastole. How long are we open and relaxed? And the venous pressure, right? We're pushing blood that's been utilized back into the right atrium, into the right ventricle. So if we have some higher pressure there, it's going to work on that extra 80% that's just flowing in and increase that end diastolic volume, make this volume greater. End systolic volume is affected by your arterial blood pressure. If the aorta has a lot of pressure in it already, it's going to have a hard time, that ventricle, forcing blood out, not allowing as much blood out of the ventricle because of that arterial blood pressure, not allowing the force from the ventricle to push blood into the aorta. Also, the force of ventricular contraction. How strong is that ventricle to push against the pressure that's in that aorta? What if you've had a couple heart attacks in the ventricle and the ventricle doesn't have full force anymore? Right? That can also mess with the end systolic volume, increasing that, and hence shortening our systolic volume, making that less. So, three main factors can affect our stroke volume, the amount, the volume that we push out of a ventricle. Number one, preload, kicking it in. Contractility, the contraction of the ventricle. Lastly, afterload. Are we messing with getting the blood out because there is high pressure downstream in that aorta or in that pulmonary trunk? All right, those are the cliff notes. Let's look at these individually on slides. Preload. Okay, this is a way we can regulate stroke volume. Preload is the degree of stretch of those cardiac muscle cells before they contract. So how much blood can we push into those ventricles? All right, what kind of pressure do we have behind it, that venous return pressure? And how much stretch do we have in these muscles? Is your heart hardening? Is it still nice and pliable? This is going to affect preload. So cardiac muscle exhibits a length-tension relationship, right? If we stretch it too far, it's going to tear its muscle, just like any of your other muscles would in your body. Your skeletal muscles, your cardiac can do the same. So most important factor stretching cardiac muscle is that venous return I mentioned, the blood returning to the heart, the pressure on the back side, okay, coming up through your inferior or superior vena cava and rolling that blood into the right side of the heart there. Slow heartbeat and exercise can increase that venous return. Increased venous return then distends and stretches the ventricles, which is going to increase the contraction force as well. So if they fill up more, they're usually going to squeeze out more. Same thing, back to that balloon. If you just blow 2 puffs in the balloon and let it go, it'll just kind of, and that's it. If you fill it up to the point where it's going to pop and let it go, there's a major force because you really stretched it to get back to normal and really push that blood out or really push the air out. In the case of that balloon, it increases the contraction force. So preload definitely affects stroke volume. Second thing that affects it, contractility, the contractile strength of your heart, of that myocardium. Right, and that can be increased different ways or decreased. Increased by, remember, we can have the nervous system tie in, that autonomic sympathetic stimulation. All right, it can actually have regulation and increase that calcium influx. And calcium, lets actin and myosin hang on to each other longer and squeeze. We'll have more of those cross bridges, so we'll have more contractility. Not only the nervous system, being a communication system, can affect the heart. Don't forget about those hormones we just studied. Thyroxine, major metabolic hormone there, can have effects on contractility, up in the dosage, and definitely epinephrine, right? Fight or flight hormone, that is going to have a direct effect on those cells to increase the contractility. Opposite side, how do we decrease the contractility? We can have calcium channel blockers. There are drugs that can do this, okay, which will in effect decrease the blood pressure. Dihydropyridine here being one of them. And no, I'm not going to ask you to name off dihydropyridine, but calcium increase can cause more contractility. So yin to yang, calcium channel blockers can decrease the contractility and hence decrease your blood pressure. The afterload effect. So we've had the preload, we've had the contractility, now let's have the afterload effect. The pressure ventricles have to overcome to push the blood out is downstream. If there's already too much blood, too much pressure in either the discharge vessels here, we're going to have to squeeze harder, push stronger to get that blood out and open those semilunar valves and get her gone and out of the heart. It's the pressures the ventricles have to overcome to eject the blood out of those semilunar valves. Hypertension, high blood pressure definitely increases afterload because we got to fight to get blood out where there's so much pressure already building up. Okay, this is going to result in an increased end systolic volume. This line will come up here because not as much blood's going to be pushed out. We're going to leave more than just 50 mils in the heart. And that will then shrink and reduce the stroke volume, the blood being exiting from the heart. So that's afterload. Quiz time. Atrial systole occurs blank, the firing of the sinoatrial node. So atrial systole occurs before, after, with, or alternately with the firing of the sinoatrial node. Picture your heart. Picture the nodes. What do you think? After. Correct. Atrial systole occurs after the firing of the sinoatrial node. The sinoatrial node has to fire off to relay that membrane potential being flipped and running through those little gap junctions and talking to all those cells in the atrium to allow for them to contract. It's not perfectly timed. Remember, it's a wave effect. So it's going to occur after. We got to fire off first that SA node. The majority, 80% I mentioned, of ventricular filling occurs blank. Is it during late ventricular diastole? Is it during passively through blood flow alone? Is it with the atrial systole, the atrial contraction? Or is it both late ventricular diastole and passively, just by the blood flow alone? 3, 2, 1. Correct. Passively. 80% is passive. 20% is from the atrium contracting and pushing that last little bit into those ventricles. Continuing on, we talked about regulation of stroke volume. Now let's talk about regulation of the heart rate. Increasing the heartbeat, decreasing the heartbeat. We have different factors. Time, chrono, meaning time, positive chrono, positive time factors, and negative time factors. So the positive chronotropic factors increase heart rate. Positive, increase. Negative chronotropic factors decrease your heart rate. So start thinking, what hormones might affect this? What contact with your autonomic system might affect this? You already know the answers. Autonomic nervous system. Positive chronotropic factors, we're going to increase the heart rate. So that is going to be the sympathetic nervous system, increasing the heart rate and even force of contraction. Remember, these nerves are going to reach down from the medulla oblongata, all right, and talk directly to the SA node, the AV node, and even tie into that left ventricle to make sure it squeezes super hard and kicks out a larger stroke volume. So we're increasing heart rate here and stroke volume with the sympathetic nervous system. Okay, emotions, physical stressors, that fight or flight is going to kick off, and norepinephrine is going to cause that pacemaker, our first one, that SA node, and even talking to the AV node to fire more rapidly, so become more leaky for sodium and reach threshold even faster, increasing your heart rate, and also going to increase the contractility as well. Negative factors, what's going to slow the heart down? The other yin to yang for autonomic, the parasympathetic. So we are going to roll down through vagus nerve, number 10. Roll down and talk to our pacemakers, the SA and AV nodes. The SA and AV nodes. All right, and slow them down using acetylcholine. Right, this is going to hyperpolarize those pacemaker cells by pushing calcium ions. Right, and this is going to take it longer than that cell with them leaky sodium channels to reach threshold. When we talk about this, we actually say the heart at rest exhibits vagal tone because the vagus nerve is controlling the heart rate here. And that's usually who's in control most of the time, is the parasympathetic. It has the dominant influence unless you get scared and have that fight or flight. So that is why most people don't beat their SA node at like a 75 pace all the time. But the parasympathetic gives it a little slow to its roll and lowers the heart rate a little bit. Of course, if the nervous system is going to talk, our second communication system is going to talk, and we are going to have chemical regulation with them sexy little hormones of our heart rate. Epinephrine. Okay, we know that's from the adrenal medulla, the very center of the adrenal glands sitting on top of your kidneys. Those can increase heart rate contractility. We have thyroxine, which we already mentioned, can increase the heart rate there as well. That's a major metabolic hormone. And it even enhances the effects of those adrenal hormones, the norepinephrine and epinephrine. Another chemical regulation isn't just hormones, but those actual ions themselves. The intracellular and extracellular ratio of positive and negative, it needs to be maintained for normal heart function. Right? Sodium, calcium for the release from the sarcoplasmic reticulum, potassium as well, helping for that membrane potential. These all need to be maintained, and those are considered chemical regulations as well of your heart rate. Those are out of whack, you're in trouble. Many other factors can influence your heart rate, not just nervous system, endocrine system, the ions, but your age. All right, fetus has the fastest heart rate. Super tiny little heart, needs to push that blood around super fast to get to everybody. So highest heart rate there in the fetus. As you get bigger, larger, you usually have a slower heart rate because you're able to push more volume with each beat. So you don't have to beat super fast when you're only pushing a little thimble full of blood. All right, larger, slower heart rate. Men have a larger heart rate than the ladies. You know, on average, size is a factor there. Gender, females faster than males. Again, a size issue as well as some hormonal effects as well. Exercise, of course, is going to increase your heart rate. Right? We need to get more oxygen, more nutrients to our cells because they're working harder than sitting on the couch. Even your body temperature. Okay, your heart rate increases with body temperature increase. When you have a fever, your heart beats faster. All right, you know, temperature in water. Water starts moving around faster, the molecules start boil. Same thing here, your body temperature increases. Great figure in the book here showing all the different factors involved in determining your cardiac output. Right? At the base here, you have cardiac output. And we know that the calculation is cardiac output equals stroke volume times the heart rate. So how do we mess with the cardiac output and make it increase? We can increase the heart rate several different ways here by a decrease in parasympathetic activity, an increase in sympathetic activity, again caused by exercise or fright, anxiety, that fight or flight response. Just working out can do this too, increasing your heart rate, increasing cardiac output. How do we increase stroke volume? I mentioned this by increasing that end diastolic volume because of preload. Okay, this is all with the venous return. Again, rolling into exercise, rolling into the heart rate, allowing for the ventricles to fill longer if the heart rate is decreased. Stroke volume also can be increased by a decrease in end systolic volume because we've increased contractility, and that can tie into your sympathetic activity as well. And also some of those hormones, epinephrine, thyroxine, excess calcium there inside the muscle cells, allowing actin and myosin to play with each other a little bit longer. But big picture here, cardiac output equals stroke volume times heart rate. And know how these can be increased or decreased to increase or decrease your cardiac output. The input to the heart from the cardioinhibitory center in the medulla oblongata primarily affects what? What does the cardioinhibitory center, those nerves, tie into? SA and AV nodes, the subendocardial conducting network, or those Purkinje fibers, cardiac contractile fibers, or maybe the AV bundle in that septum. 3, 2, 1. Yay, you got it. SA node and AV node is where those are going to tie into. All right, again, rolling off that vagus nerve, number 10. Imbalances. Lots and lots of imbalances that we can have. Let's just touch a few. Hypo and hyper, we know these terms. Hypo, low, hyper, high. Calcemia should make you think of what? Yes, you are correct, calcium. So low calcium, if we don't have that in there to drop the troponin and tropomyosin ropes to allow actin and myosin to get together and contract, that is going to cause problems. It's going to depress the heart, not allowing it to contract as well. Hyper, too much calcium in there, is going to cause an increase in heart rate and contractility because we're going to have those ropes dropped even longer. Okay, for actin and myosin to be able to get together, hold on to each other, and cause that contraction. Hyper and hypo again. Kalemia, K. Think the periodic table? Yes. Potassium. Hyperkalemia, too much, is going to alter that electrical activity because it's going to mess with the resting rate of the membrane, and it's going to cause an even greater blockage to get to threshold. Okay, it's going to alter that electrical activity. Heart block, cardiac arrest can occur here. Not enough potassium. Feeble heartbeat. You can have arrhythmias where we have a heartbeat that's not regular. And so keeping your electrolytes, keeping your ions, calcium, potassium, very important. Eat that banana. Couple other imbalances, tachycardia and bradycardia. You've heard probably on TV or maybe even in real life, they're braiding out. All right, that's what we're talking here with bradycardia. But first, tachycardia. Very fast. Okay, abnormally fast heart rate, something over 100 beats per minute. Okay, if this is persistent, it could lead to your heart flipping out and going into that spasm again, fibrillation, where it's having its little seizure and just going ballistic because we're not giving the time for the heart to reset and let that SA node keep the beat. So that can be a problem if they go into tachycardia. Might have to give them a shock and get them back into normal sinus rhythm. For the bradycardia, low, okay, heart rate slower than 60 beats a minute. Now for couch potatoes, that's pretty stinking low. For people that exercise and are very conscious of their health, that might actually be a healthy heart rate. All right, so it depends on the individual what bradycardia is going to be. But in normals, averages, we're looking at about 60 beats per minute. All right, if we go too slow, too low, again, we're not pushing the blood through for the body, so we might not have an adequate blood circulation. For those that do endurance training, getting your heart rate that slow is fabulous because then you have a greater weight, a greater distance that you can speed up your heartbeat without it exploding on you. So this is very desirable for endurance training individuals to have a slow heart rate because it gives them a chance to have a faster and even faster heart rate when they are performing. More imbalance, congestive heart failure. I'm sure you've all heard of this, congestive heart failure. It is a progressive condition, which means it just continues and it's going to get worse. Okay, the cardiac output with congestive heart failure is so low that blood circulation is inadequate to meet your tissue needs. You're not feeding the cells in your body the nutrients or the oxygen or clearing out the waste that they need to be happy and healthy. All right. You're going into heart failure. Reflects a weakened myocardium, so the muscle cells are weak. They're not pushing it around as they should and having that cardiac output necessary. Can be a couple things. It could reflect coronary atherosclerosis, which is the hardening, clogged arteries. That's not good. Persistent high blood pressure, right? That afterload, not allowing the heart to give a full stroke volume. Okay, that would definitely be a low cardiac output if we can't get it out of the heart and get it to the body. Okay, multiple myocardial infarcts, so multiple heart attacks causing damage in several different areas can also lead to this congestive heart failure. Right? All of these are weakened muscle that aren't doing their job right and getting us to that congestive heart failure. Oh my goodness, the list never ends, but you're going to see this and more in the future, I'm sure. Pulmonary congestion and peripheral congestion. All right, these are also imbalances. This is where we're going to have a backup, a congestion. Remember I mentioned the heart is two separate pumps. So if we have pulmonary congestion, that is the left side failing. Okay, blood is going to back up into the lungs because the left side is not getting that blood out to the body. Pulmonary congestion. It's going to congest and back up in the lungs. Remember, we want to have even flow. But if one side of the pump's not working right, we aren't going to have even flow through the body, are we? Other side, peripheral congestion. This is when the right side fails, the deoxygenated side. So if this is not pushing blood to the lungs to be reoxygenated, the backup is going to be into the body. Blood pools in the body, its organs, that's not good. Not getting the blood supply needed to re-nutrient and reoxygenate everybody. Failure on either side, all right, left or right, is ultimately going to weaken the other because the other is going to try and work harder to make up for that loss of work on the other side. All right, so failure on either side is ultimately going to weaken the other side. This is going to be a progressive condition as well. All right, with not a good end result. So tell me, predict what would happen to the end systolic volume, your ESV, right here, if contraction force were to increase. What's going to happen here with your end systolic volume if contraction increases? Would end systolic volume decrease? Would it increase? Is it just going to stay the same? ESV is not affected by contraction force. What do you think? If we squeeze harder, I bet you that's going to go down. Yep. End systolic volume would decrease. We'd have less blood left in the heart and the ventricles, which means your stroke volume is going to increase. All right, your heart seems to pound after you hear a sudden loud noise, boom. and your heart's pounding in your chest, and you can probably hear it at some point. This increased contractility is what? What is causing the heart to do that? Is it vagal nerve impulses? Okay, A. Is it because when a gasp of surprise is emitted, a Frank Starling law of the heart is evident? Due to norepinephrine causing threshold to be reached more quickly in our SA nodes, our AV nodes? Or is it because acetylcholine release is inhibited? What do we think? 2, 1. Yes, so says Johnny Depp. It is due to that norepinephrine causing threshold to be reached more quickly in our pacemaker. So fight or flight right there. And it looks like he is not doing fight or flight. He's just freaking out and freezing up, which can also happen. All right. Why is high blood pressure damaging to the heart? This is something I didn't say specifically, but I bet you can figure it out. High blood pressure. Why does that beat up this perfect little organ here? Is it with high blood pressure, the blood is more viscous? Is it thicker and harder to pump? Is that what high blood pressure is? The heart rate slows down to dangerously low levels if blood pressure is too high. So if pressure is too high, does the flow decrease? Is it due to an increased afterload? The left ventricle must contract more forcefully to expel the same amount of blood to try and get it around the body. Last but not least, D, is the sodium concentration increases during high blood pressure, and that is toxic to the myocardium. So an increase in sodium actually kills, it's toxic to your muscle cells. What you think? When in doubt, guess C. Yep, so due to the increase in the afterload, that high pressure volume of blood, and the ventricles just have to try and overcome that to push out, we are going to weaken that muscle wall. Look at that. Enlarged heart, enlarged ventricle, the thinning of that very thick muscle wall there is gone. All right, so high blood pressure is a sign that the heart and blood vessels are being overworked. We have too much pressure in the system. It's going to blow at some point. Something's going to break down. So if untreated, the disease can lead to atherosclerosis and congestive heart failure. So we want to keep that heartbeat, the flow, the pressure in nice homeostatic ranges. And the blood pressure, nice average, happy, healthy, 120/80. That's all I have for this section. We have covered 3 different topics. On to the next.